We would like to express our deep gratitude to the International Academy of Osteopathy and all the instructors who gave us their best of effort to educate us all through the last 5 years about the great science of osteopathy. A special thanks to our promoter, Levin, whose effort to guide us through the completion and success of this work is deeply appreciated. We would like to extend our thanks to Dr. Amr Abdulaziz, the consultant of chest disease at Hawani University, Cairo, Egypt, for assisting us all through this study. Asthma is an inflammatory disease that affects the large and small airways, and it leads to decrease of airflow rate in the respiratory system. Airflow obstruction is secondary to mucus production by respiratory epithelium and also because of the bronchospasm that occurs. Patients with asthma would have bouts of breathlessness, chest tightness, and cough, and sometimes wheezing, and this is called asthma attacks. The diagnosis of asthma involves a thorough medical history, physical examination, objective assessment of the lung function. Usually, spirometry is used for that to confirm the diagnosis. The autonomic nervous system controls several aspects of the airway function, so abnormality in the autonomic regulation of the airway may lead to bronchospasm, airway edema, and excessive mucus secretion. Osteopathic manipulative technique in treatment acts on the sympathetic and the parasympathetic system. The parasympathetic innervation of the lung and the diaphragm comes from the vagus nerve. The sympathetic innervation of the lung and the bronchi originate between the fourth and fifth thoracic vertebrae, and the paraspinal ganglia are immediately behind the costovertebral junction of the upper thoracic region. OMT is expected to benefit patients with asthma in many aspects. First, the reflex irritation of somatic and autonomic nerves to the spinal level causes segmental spinal dysfunction with areas of muscle stiffness and pain. Second, the mechanical disturbance affects neurological function of the chest wall by changing the tone of airway responsiveness or airway directly through the neurogenic inflammation, resulting in predisposing to asthma induction. Third, the correction of the dysfunction of vertebral subluxation by manipulation with restoration of the mechanical and nerve function should improve the airway function and assist the resolution of asthma. Fourth, the immune reaction may be involved in the pathology of the asthma development. Segments of the organs that are involved in immune action and excretion must be treated. We should examine and treat segments of the adrenal glands, the spleen, and the gastrointestinal system as well. Fifth, the presence of restriction of the lung and the diaphragm movement due to presence of adhesions or shortening of supporting ligaments would lead to limitation of lungs function and effective respiration process. So it is very important to address these lesions properly through osteopathic treatment techniques. Sixth, for breathing to happen, there must be a connection from the medullary respiratory center to the muscles of respiration. The active inspiratory centers. Neurons stimulate the nerves to the inspiratory muscle, the phrenic nerve to the diaphragm, and the intercostal nerves to the external intercostal muscles. These muscles contract, leading to expansion of the thorax, so the air is drawn into the lung. When inspiratory center neurons are not active, the stimulus to the muscle stops and the muscle relaxes, so the expiration occurs passively, working on suboccipital region C0, C2 to modulate the function of the respiratory centers may help in treating symptoms of asthma. The study, including 15 patients, 3 females and 12 males, their age varied between 20 years old and 44 with a mean of 33.3 years. Patients with stage 1 and stage 2 asthma were first examined by a single consultant of chest disease. He approved the patients to undergo osteopathic manual treatment by our team. All patients filled an asthma scoring questionnaire, and the questionnaire was repeated 4 weeks after the osteopathic treatment sessions were concluded. Respiratory function test was done before starting sessions and after completing 3 osteopathic manipulative treatment sessions. The forced expiratory volume after 1 second, FEV1, was recorded as a parameter to be compared before starting and after completing all 3 MOT sessions. Exclusion criteria included patients who suffered from stage 3 and stage 4 chronic asthma, smokers, obese patients, patients with asthma for over 5 years, and patients who suffer from spinal and bone disease that rendered OMT hazardous. Examination. Our team examined the cervical and the thoracic spine to exclude or to include any osteopathic lesions. Chest examination for the chest wallet restriction, for the shift, for thoracic chains restriction. Diaphragm motion restriction were also examined for. Hepatojugular reflux was examined before doing any maneuvers for safety. Cervical spine examination was done from sitting and supine as well. All levers were examined for rotation and side bending, inflection, and an extension. The thoracic spine was examined also to detect any lesions, either flexion or extension lesions or other lesions. Oscillation was used to examine it. If suboccipital tension was detected and suboccipital release was done, this would stimulate the medullary centers and the parasympathetic stimulation as well. If C0, C2 lesion was found, manipulation was done. Lesions of C2 to C4, which means that there is a problem in the segments of C3 to C5, which are the stimulation of phrenic nerve, then they should be treated. If intrapelvic adhesions were detected, then intrapelvic mobilization was done. Spleen decongestion and mobilization was done if perisplenic adhesions were detected as well. We recommended that our patients should do physical exercise. They should not be vigorous and they should be on daily basis as possible. Mainly just flexion, extension, rotation, and side bending of the torso. Running in place or jogging for a short time, between 15 to 30 minutes, were preferred. If the patient were able to swim in a warm, humid pool, then that would be a bonus. Some patients were involved in also in yoga classes as well. Respiratory exercises were given to our patients. They help reduce the respiratory rate and increase the tidal volume and improve the arterial oxygenation saturation. One of the exercises was exhalation with pursed lip over 4 to 6 seconds. Another exercise with abdominal respiration in the supine position and sometimes in the erect position as well. The patient would place the dominant hand on the abdomen and the other hand on the chest and they would breathe slowly through the nose and exhale with pursed lips using mainly the diaphragm. As far as FEV1 was concerned, all cases, 100% of cases, had FEV1 improved. The mean FEV1 before the OMT was 80.73, ranging from 78 to 86, and the mean after 4 weeks of OMT over 3 sessions was 88.47, with a range of 81 to 96. The mean asthma score before OMT treatment was 16.60, ranging from 14 to 19. 13 patients, that is 86.66% of our patients showed improvement with a mean of 18.93. Only 2 cases, that's 13.33% of our cases did not show any improvement in the asthma score. The overall asthma score progress is 2.33. There was no statistically significant difference between our 12 males and 3 female patients. Studies focusing on implementing osteopathic techniques to treat asthma patients are few. Some use spirometer to measure the parameters such as FEV1 and expiratory peak flow (EPF) to be compared before and after techniques. Some also used measurement of the chest extrusion to evaluate the results of their studies. Some studies depended on single technique applied to the cases and only one session were done. Other studies implemented several techniques and other studies included many sessions that extended up to months. Some studies of OMT techniques depended only on spinal manipulations, yet other studies addressed soft tissue, body organs beside the spinal techniques, and were concerned with tackling mechanical, vascular, neurological, metabolic, and psychological factors as well. In conclusion, after 3 sessions over 1 month of time of combining OMT with optimal medical treatment and breathing exercises for cases suffering from stage 1 and 2 chronic asthma, 86.66% rated their quality of life better and their asthma symptoms to be improved. There was an improvement in the respiratory function in all cases with variable degrees, and these improvements are unlikely as a result of one specific OMT uh, maneuver, but also of other elements of treatments as well. Proper nutrition, physical activity, avoidance of asthma triggering factors, and psychological status of the patients are very important elements that should be taken into consideration while treating asthma patients. We recommend that there should be further research to include more cases in the study and to also extend the follow-up period. The components of OMT which are responsible for improvement of the patient outcomes should be pointed out to be able to implement them into the asthma patient treatment programs.